Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is COVID 19 pandemic news. This is coming to you live from Houston, Texas, and today we are going to be talking about COVID 19 trial. This Ramdesivir trial for treatment for COVID 19 was just announced yesterday in the New England Journal of Medicine, and here you can see the reference. We are going to look at this study and see what we can learn from this and how we can apply this at bedside when we are dealing with the patients with the COVID-19 infection. And here is the title of the article with Dr. Beagle as the lead author. And this study involved multiple centers. We're going to talk about that in a second. This study was conducted in a randomized, double-blind, placebo-controlled fashion using intravenous Ramdesivir. Patients with COVID-19 or coronavirus infection with evidence of a lower respiratory tract involvement were enrolled in the study. Half the patients in the trial received Ramdesivir 200 milligrams on the first day intravenously, followed by 100 milligrams daily for the next 9 days, and the placebo group received similar doses of placebo in the trial. This study was funded by the NIAID. What is Ramdesivir? It is an antiviral agent that was used to reduce the duplication of the COVID viruses in SARS and MERS pandemics. It inhibits the viral RNA-dependent RNA polymerase in SARS and MERS viruses. It was also shown in animal experiments to inhibit SARS-CoV-2, which is a virus that causes coronavirus infection. Later on, it was also used in non-human primates, where it showed reduction in lung viral levels and also reduction in lung damage. So there was pretty good evidence that this Ramdesivir may be useful in patients with evidence of coronavirus infection who have lower respiratory complications. The primary endpoint in this study was to look at time to recovery as defined by either discharge from the hospital or hospitalization for infection control purposes only. The initial study was for a duration of 15 days, but as the COVID pandemic evolved, we learned that some of these patients may have symptoms of COVID for a longer duration of time, and hence the study duration was expanded to 29 days on April 2nd, 2020. Let's look at some of the numbers, then we are going to look at some of the charts and outcomes. The total number of patients enrolled in this study were 1,063. The study time frame was between February 21st to April 19, 2020. The treatment group consisted of 538, while the placebo group had 521 patients. The mean age was 58.9, 64% were male, and this study was conducted in 60 different centers, and almost 80% of them from the United States. And interestingly enough, more than 27% of the people had at least one comorbid condition, and more than 52% of the patients had 2 or more comorbid conditions. So these are all important things to remember, because this was tried in a patient population with moderate to high risk for coronavirus complications. Now let's look at the study protocol. Ramdesivir trial, as I told you, involved 1,059 patients. The mean randomization time was 9 days after symptoms started. Why 9 days after the symptoms started? If we are going to give an agent to reduce the viral load. If we are going to give an antibiotic to cut down the bacterial growth, when would you do? You would do it at the earliest possible time. If you have a patient in the emergency room with pneumonia, you're expected to diagnose and treat those patients with antibiotics within 3 to 4 hours. So I think this is one of the things that I raise question as to would it have been beneficial if this was given on the first day of when these patients were randomized for the trial. Anyway, the 538 treatment group received, of course this was double blinded, so you didn't know who was getting what. The treatment group received 200 milligrams of Ramdesivir IV on day 1, and then it received 100 milligrams. There's a typo here, for days 2 to 9. And the placebo group basically received placebo for the entire duration of the study. Here are some demographics of the two groups. Some of the things I would like to point out are the comorbid conditions. Almost 50% of them had hypertension. Obesity was noted in 37% of the population, and diabetes was noted in almost 30%. So we do have a significantly higher risk group combined with the age of 58 years mean age. So this is a moderately high risk group. They use 8-point scale, Ordinal scale, to determine on a daily basis how these patients are coming along. If these patients were not hospitalized and there was no limitation of their activities, it was graded as 1. And if they were not hospitalized and they needed some oxygen, it was graded 2. If they were dead, they were graded as 8. And the remaining numbers are for hospitalized patients, going all the way from not requiring supplemental oxygen to requiring either ventilator or ECMO. So these are the different cardinal, as we can see here in this chart, the distribution of those cardinal points we talked about. The majority of them were in category 5, which accounted for almost like 40% of the population. Let's go back and look at 5 just for the sake of completion. 5 hospitalized requiring any supplemental oxygen. That's a pretty good indication. Any time there is a drop in oxygen, that's the time to treat these patients and not wait until they get on a respirator or ECMO. Anyway, let's move on. The primary and secondary endpoints. As we said, the primary endpoint was to look at recovery time in days. In the Ramdesivir group, it was 11 days, and in the control group, it was 15 days, with a 95% confidence interval for Ramdesivir, 9 to 12, and for the placebo group, 13 to 19, with a p-value of 0.001, which was highly significant. They also looked at a mortality data, which is incomplete, so we should not draw any conclusions on this particular data at this time, since they have to collect data for the entire 29 days duration to see how much difference it makes. But nonetheless, there is a tendency towards reduced mortality in the Ramdesivir group compared to the placebo group, with a hazard ratio of 0.70. And interestingly enough, almost 20% of them had significant serious adverse events. Here's the recovery ratio. Before we look at the serious adverse effects, let's look at the recovery ratio. And as we saw in category 5, the recovery ratio was most optimal, which also suggests the best time to catch these patients or get these patients on treatment is when they have minimal oxygen requirements, when there is very early sign of decompensation. That's the time to get it. But by the time they reach category 7, where they are ventilator dependent or they are dependent on high supplemental oxygen, it doesn't make any difference whether they are treated with Ramdesivir or a placebo. So, ladies and gentlemen, here's an important message, and this applies to all the agents that we use to reduce the viral load, including plasma transfusion, which I'm going to talk about towards the end of this presentation. And again, in category 4, also they saw a significant benefit in terms of Ramdesivir improving the recovery ratio. All right, so as we said, they also looked at the time of intervention. In the first 10 days, about 2/3 of them were in the first 10 days, and the recovery ratio of 1.28. And however, if it was greater than 10 days, it was actually even better. It's hard to interpret this data because, as I said, if you have a patient with pneumonia, you want to treat them with antibiotics on day 1, and that makes perfect sense. If we are going to treat a patient with a potentially dangerous virus infection, such as coronavirus infection, the best time to treat is on day 1 or day 2, so that we have the best chance of minimizing pulmonary damage, thrombosis, necrosis, and permanent infiltrates. We talked about the Ordinal scales, and improvements were noted in a 1.5 ratio compared to the placebo group, and this was also statistically significant. So in other words, when the patients who were treated with Ramdesivir showed significant improvement in not only the length of stay, but also in the level of dependency of supplemental oxygen, mechanical ventilation, or for that matter, pressors, things like that. Okay, here are some of the charts which sort of highlight what I have said. In the overall improvement, Ramdesivir did better compared to the placebo group. Similarly, patients who were not receiving oxygen also did better compared to the placebo group. And if you look at patients who were receiving oxygen, had a much better result with Ramdesivir compared to the placebo group. However, patients who were on high flow oxygen or non-mechanical ventilation did not show much improvement. We are talking about the group 7 or 6, and that's why we don't see any improvement. So going backwards, I think if we catch these patients, ordinal category like 1, 2, or 3, that's the time to treat these patients with Ramdesivir. So repeatedly, I am coming back to the focus of early treatment to reduce the viral load, to reduce the capillary damage in the lungs, to reduce microthrombosis, to reduce alveolar destruction, infiltration, pneumonia, and hypoxia, cytokine storm. If you want to treat that, we should do it before there is lung damage. Anyway, let's move on. Let's move on to patients receiving mechanical ventilation. It actually made very little difference. Point we want to drive home is you want to treat these patients, you treat them early. At the earliest sign of coronavirus infection. Thus, it's like taking Tamiflu. You take Tamiflu before you have the significant disease. On the first signs, you are sneezing or having cough, you go and take this medication with the hope of reducing the viral load, minimizing the symptoms. If we use these principles, I think there's a good chance of getting better earlier. Mortality data I already talked about, but this study is incomplete. Maybe in the next report they may come up with the data once they have analyzed the complete 29-day studies. There was significant morbidity in both these groups. 21% of the people in Ramdesivir and 27% of the people in placebo group had significant adverse effects. Acute respiratory failure, hypotension, viral pneumonia, acute kidney damage, and all of these are related to the rapidly expanding viral overload, damaging the lung tissue to start with, creating pneumonia, leading to respiratory failure, septic shock, superinfections, and of course acute kidney injury. If we want to address this issue, I think the time to treat these patients should be before there is any evidence of initial pulmonary insufficiency or oxygen deficit. Anyway, if you look at this graph, it tells you that Ramdesivir has a much better odds of helping patients in respect to their geographic location, race, ethnic group, age, sex, symptoms, and comorbid conditions, with the exception of those who are on ventilators or ECMO. So this is a very promising drug which was been very useful, and in conclusion, Ramdesivir was superior to placebo in shortening the time to recovery in adults hospitalized with COVID-19 with evidence of lower respiratory tract infection. After these results, they had to change the protocol for the second time. They felt it was important to treat those people who were on placebo with Ramdesivir because of the outcomes from this study. Finally, the benefit was most apparent in patients with a baseline Ordinal score of 4 to 5, and this was most likely due to larger sample and also perhaps because of the early stages in which these patients were treated before they developed significant lung complications. Okay, here are some of my personal observations which I have already stressed many times during this presentation. Any preventive or therapeutic measures we use in treating a virus infection should be instituted early before the viral load gets out of control. It's the same thing with flu. If you take Tamiflu, it's the same thing with pneumonia. You want to catch it early and treat them with antibiotics. So that's something I would like to see, using these agents in the earliest stages to minimize the viral load on the lungs. Should be done at the earliest signs, and the same principles must be applied to convalescent plasma transfusion. Very often, the convalescent plasma transfusions are used in desperate patients who are dying. In the last-ditch effort, these plasma transfusions are used. Ladies and gentlemen, what does the vaccine do? The vaccine produces antibodies before you get infection. And when you give plasma, what does the plasma provide? Plasma provides antibodies to fight against the virus multiplication and replication. So if we are going to reduce the virus multiplication and replication, when is the best time to use the plasma transfusion or any drug that reduces viral multiplication? That is before it gets out of hand. So with reference to plasma transfusion also, I would like to see if it's being used, it should be used at the earliest signs of any pulmonary decompensation, with the hope of reducing the viral load, reducing the pulmonary damage, and hopefully saving lives. Finally, I would like to see a combination of agents that can reduce the virus, that can minimize the viral multiplication, such as Ramdesivir along with plasma transfusion. So we have like a multimodality approach to minimizing the viral damage on the lung tissue. That's my take on this presentation. I like this Ramdesivir. Hopefully this Ramdesivir, when combined with plasma transfusion, could save more lives in the future. Ladies and gentlemen, I am Dr. Nik Nikam, and you have been watching COVID-19 Ramdesivir trial results. Thank you so much for watching, and please do subscribe to our YouTube channel. We will see you next. Before that, I wanted to tell you we got more than a dozen videos on COVID-19 pandemic, and please do watch all those videos. Thank you so much for your time.